So next, we will have a discussion on the multiple endocrine neoplasia syndromes and autoimmune polyendocrine syndromes. First, about the men's syndromes. This is the table from Harrison, which summarizes the different clinical features that you associate with men 1 syndrome. So characteristically, it has got a triad of parathyroid lesion, the gastroenteropancreatic neuroendocrine tumors, and the pituitary lesions. And these are the three important features, and if a person has got 2 out of these 3, then clinically you can make a diagnosis of men 1 syndrome, or else you will have to resort to the genetic testing. And apart from these 3 classical manifestations, there are a lot of other features like the adrenocortical tumors, rarely pheochromocytomas, the neuroendocrine tumors at other areas like thymus, bronchus, and gastric areas, then the cutaneous lesions like lipomas, angiofibromas, etc. are also associated with men 1 syndrome. So the menin gene is the tumor suppressor gene, and the inactivating mutation of this gene can result in men type 1. The most common manifestation is hyperparathyroidism, where it is due to combined parathyroid adenoma with parathyroid hyperplasia. So both can be present in a hyperparathyroidism in men 1 syndrome. The most common pituitary tumor is prolactinoma, followed by somatotroph tumor. But now more and more data is emerging that the non-functioning pituitary tumor may be even more common than prolactinoma, but the standard textbooks still mention prolactinoma as the most common tumor, so it is better to go by that. And the most common skin manifestation would be angiofibroma followed by collagenoma, but in our clinical practice what we usually see and encounter is the collagenoma in Indian population. So adrenocortical tumors, which can be seen in up to 30 to 40% of individuals, are usually non-functioning. And about the gastrinoma in men 1 compared to the sporadic individuals, they are present more on the duodenal wall, multiple, small, and sometimes it may be present outside the gastrinoma triangle. Most of the time it would be present within the gastrinoma triangle, but sometimes it is present outside the gastrinoma triangle also. So it is more likely to be very small, the submucosal, and multiple. So how are you going to make a diagnosis of gastrinoma? Because the clinical features would be like this. The patient would be having severe dyspeptic symptoms, will be proton pump inhibitor dependent. Such symptoms may be there. Daily 2 or 3 doses of H2 receptor blockers or PPIs they may have to take. So in individuals whom we suspect a gastrinoma, you have to take a fasting gastrin sample. If it is more than 1000 picogram per ml at a gastric pH of less than 2, how can we get a gastric pH? By using a Rice tube, or even from an endoscopic procedure, you can get the gastric aspirate and can measure the pH. If it is less than 2, with the corresponding gastrin of more than 1000 picogram per ml, you can definitely make the diagnosis of gastrinoma. But of course, you would have to stop the proton pump inhibitor for at least 1 week before the gastrin assessment. So some of the one-liners from men 1 syndrome. How are you managing the hyperparathyroidism in a patient with men 1 syndrome? So when you identify a parathyroid adenoma in a sporadic individual without any other syndromic association, what we go is you resect the culprit parathyroid adenoma and leave all the other parathyroid glands alone. But in men 1 syndrome, even if you identify a solitary parathyroid adenoma, as I've mentioned, one lesion could be adenoma and the other gland should be simultaneously be having parathyroid hyperplasia. So if you are removing only that lesion where adenoma is present, in the future the other lesions can become hyperplastic and become an adenoma also. So it is better to do a 3.5 parathyroidectomy at the first sitting itself with transcervical thymectomy. What is the purpose of doing a thymectomy along with parathyroidectomy? There are 2 purposes. One is that sometimes there can be ectopic parathyroid glands or parathyroid adenomas being located within the thymus in a patient with men 1 syndrome. So by doing a thymectomy, we are removing that source. And second point is that one of the common causes for death in a patient with men 1 syndrome is the thymic carcinoids, which are very aggressive. So when you are exploring the neck, if you are removing the thymus gland, you are preventing the thymic carcinoids to develop. So that could improve the survival in a patient with men 1 syndrome. That is why you advise for 3.5 parathyroidectomy with transcervical thymectomy as the standard procedure for treatment of hyperparathyroidism in men 1 syndrome. So when will you give surgical treatment for gastronoma? When the tumor size is more than 2 centimeters. The medical treatment for gastronoma is mainly symptomatic with proton pump inhibitors and with somatostatin analogs to reduce the gastrin secretion and to prevent the tumor growth. So in equivocal cases, when you are not able to do a gastric pH or when the serum gastrin is not very elevated, then one thing you can do is that you can do a stimulation test with secretin, or you can do an intra-arterial calcium infusion test and document the increase in serum gastrin by at least 120 picogram per ml. Then you can make a diagnosis of gastronoma. So, and other tumors which are increased in men 1 syndrome include breast cancer as well as meningioma. Both of these have increased risk in patients with men 1 syndrome. And about the men 1 insulinoma, it occurs at earlier age compared to sporadic variants. They are multiple and are associated with increased cancer risk. So the most common cause of death in a patient with men 1 syndrome is the metastatic neuroendocrine tumors, which are located in the gastroenteropancreatic region, followed by thymic carcinoids. Now coming to how are you going to monitor for different tumors in a patient with multiple endocrine neoplasia type 1. For parathyroid tumors in a patient with a known case of men 1 gene mutation, you have to start monitoring from 8 years of age, yearly with calcium and PTH levels. The calcium may be enough, we need not do PTH at every visit. So the earliest age at which you should start monitoring for the clinical features is at 5 years, where there is risk of insulinoma, anterior pituitary tumors. So these are the two things which can appear as early as when the individual is 5 years old. So you should screen for that at 5 years of age. So 8 years you will have to go for parathyroid. Then 10 years you have to look for other pancreatic neuroendocrine tumors and adrenal tumors. At 15 years you look for thymic carcinoids, and from 20 years onwards you look for gastronoma. This is the timeline for starting the screening in a patient who is a first degree relative for a known case of men 1 syndrome, or who has a known or a proven germline mutation in the menin gene. So other neuroendocrine tumors associated with men 1 syndrome include lipoma, also known as WDHA, which is the acronym for watery diarrhea, hypokalemia and echlorhydria, also known as Werner-Morrison syndrome. You can also have glucagonoma, which has got a characteristic skin lesion in the form of necrolytic migratory erythema occurring in the periorificial region or in the buttocks or the perianal region. So it has got features like anemia, weight loss, stomatitis and diarrhea. The patient would be having uncontrolled diabetes mellitus with increased risk of deep vein thrombosis and pulmonary embolism. So in a men 1 patient who is having hypoglycemia, you should think of the presence of insulinoma. Who is having uncontrolled hyperglycemia, you should think of the possibility of glucagonoma. These two clinical scenarios that you should keep in mind. And what about men 4 syndrome? It is actually a variant of men 1 syndrome with a different genetic origin. It is due to mutation in the CDKN1B, which is a cell cycle regulator gene. Again, the most common features are the parathyroid lesions and the pituitary lesions. And the other tumors like the pancreatic neuroendocrine tumors, adrenal tumors and the cervical tumors, the neuroendocrine tumors of the cervix have also been documented in men 4 syndrome. It's due to CDKN1B gene mutation. Now coming to the next men variety, which is the men 2 syndromes. You have 3 variants. You have the men 2A, the men 2B and the familial MTC. So what about men 2A? So all of these are due to germline mutations in the RET gene. So RET gene is the acronym for rearranged during transfection. So the full form of RET is rearranged during transfection. So in men 2A, men 2B and familial MTC, medullary thyroid carcinoma is present in almost 100% of cases. In 2A and 2B, pheochromocytoma are present in 50% of cases. And hyperparathyroidism is present only in men 2A, whereas in men 2B, hyperparathyroidism is absent. The other specific features which differentiates men 2A from men 2B are the features like Hirschsprung disease and cutaneous lichen amyloidosis. Whereas in men 2B, you have specific features like mucosal neuroma, intestinal ganglioneuromatosis, and thickened corneal nerves. So the men 2A and men 2B can both present with constipation, but the mechanism could be different. The mechanism of constipation in men 2A could be the rare association of Hirschsprung disease, whereas men 2B resulting in constipation could be due to gastrointestinal neuromatosis. But again, the genetic origin in these three conditions are also different. In men 2A, the common mutation include the mutation in the codon 634 and 883 of red gene, whereas in men 2B, it is a mutation in codon 918, and in familiar medullary thyroid carcinoma, it is in the mutation of codon 618. So familial MTC has feature of MTC alone with no pheochromocytoma, no parathyroid lesion, no other skin or skeletal manifestation. So the extra endocrine features of men 2A and men 2B are extremely important and are many times that they have been asked in the exams also. So in a patient with young onset MTC, you should always think of the underlying possibility of a men 2A or men 2B, where the patient could be harboring a silent pheochromocytoma. So it is important to screen for pheochromocytoma before proceeding with thyroidectomy, because the patient can go in for a life-threatening crisis during the intraoperative or postoperative period. So as we just discussed in the medullary thyroid carcinoma, the definitive treatment for medullary thyroid carcinoma is total thyroidectomy with prophylactic bilateral central lymph node dissection. And the tumor markers for medullary thyroid carcinoma include calcitonin and carcinoembryonic antigen. So how are you going to screen for individuals who are a known first degree relatives of patients with men 2A and men 2B? And if those who are having a germline mutation of codon 918, that is men 2B, you should do prophylactic thyroidectomy within 1 year of life and pheochromocytoma screening from 11 years. For codon 634 and 883 mutation, that is men 2A high risk mutation, prophylactic thyroidectomy within 5 years and pheo and parathyroid screening from 11 years of age. In all other codon mutations resulting in men 2A, the prophylactic thyroidectomy is not indicated at a specific time point. It is done only when the calcitonin levels are elevated above the upper limit of normal, and you start pheo and parathyroid screening from 16 years onwards. So in codon 918, the pheo screening from 11 years, codon 634 and 883, the pheo screening from 11 years, and for all other codon mutation, pheo screening from 16 years. So you can just look at these images. This is the typical distribution of the cutaneous lichen amyloidosis in the scapular region of the back. You will have the cutaneous lichen amyloidosis, and this is the typical mucosal neuroma associated with men 2B syndrome, and this is the medullated corneal nerve fibers again associated with men 2B syndrome. So you should be wary of the extra endocrine features associated with this men 2 syndromes. So again, the point we have discussed, the RET mutation specific tyrosine kinase inhibitors for medullary thyroid carcinoma are selpercatinib and pralsetinib. So now coming to the other group of disorders called multiple endocrine and other organ neoplasia. So here there are neoplasia involving the multiple endocrine glands, and there is neoplasia involving the other non-endocrine glands also. So the most common among these two include the neurofibromatosis and von Hippel-Lindau syndrome. So this table summarizes the endocrine and the non-endocrine features of all these syndromes along with the culprit gene mutations. You can go through that. So among these of specific importance and which may be asked as a clinical question is the hyperparathyroidism jaw tumor syndrome. So again, there is risk of multiple parathyroid adenomas, and with increased risk of parathyroid carcinomas also. And in thyroid, there is increased risk of Hertel cell adenoma. But unlike men 1 syndrome, you don't go for a 3.5 parathyroidectomy in HPT-JT syndrome, because it is not a mandatory thing that all the parathyroid glands will be involved. Sometimes there will be solitary gland involvement as well, which no future recurrence in the other glands. So go for the resection of the involved parathyroid glands when the patient develop hypercalcemia. So if the patient, you are identifying a adenoma in the right inferior, you go for the resection of the right inferior parathyroid gland and you leave all other glands alone. In the future, if the patient develops a left superior lesion, then you go for the left superior resection. So you don't go for 3.5 parathyroidectomy usually in a patient with hyperparathyroidism jaw tumor syndrome. And the typical feature of this is the ossifying fibroma that is associated with this lesion, and along with that, the patient can also have renal cyst and tumors and inherited in autosomal dominant pattern. So neurofibromatosis, the common endocrine features include pheochromocytoma, which is not very common, present only in 1 to 3% of NF1, pancreatic neuroendocrine tumor, especially somatostatinoma, and extremely rarely it can be associated with primary hyperparathyroidism as well. The typical features include the cafe au lait macules with regular borders, and whereas in McCune-Albright syndrome, the cafe au lait macules have irregular borders and it will not cross the midline. So that is how you will differentiate the cafe au lait macules in the neurofibromatosis 1 and McCune-Albright syndrome. And the Cowden syndrome, the endocrine feature is the follicular thyroid cancer, and the Carney complex we have discussed in detail. And the von Hippel-Lindau syndrome, you have pheochromocytoma and pancreatic neuroendocrine tumor. The pheochromocytoma is specific in such a way that it is the only pheochromocytoma where the norepinephrine secretion is predominating over the epinephrine secretion. The mechanism we have learned while our discussion in the adrenal section. And it has got non-endocrine features in the form of clear cell renal cell carcinoma, retinal and cerebellar hemangioblastoma, as well as endolymphatic sac tumors. The one specific point about McCune-Albright syndrome is that it is not an inherited condition, and the mutation in the GNAS gene, it is a post-zygotic mutation. Now coming to autoimmune polyendocrine syndromes, you have the classification which is called as a Neufeld and Blizzard classification. You have 4 variants of APS. APS1 with the triad of hypoparathyroidism, mucocutaneous candidiasis and Addison's disease. Type 2, you have Addison's disease with associated thyroid disease, type 1 diabetes or vitiligo. Type 3 means thyroid disease with other combinations apart from Addison's disease. Type 4 is all combinations excluding hypoparathyroidism, Addison and autoimmune thyroiditis. So different combinations are being categorized as APS 1, 2, 3 and 4. So the classical triad of APS 1 is what we call as the Whittaker triad, and Schmidt syndrome is the name given for Addison's disease plus either type 1 diabetes or autoimmune thyroid disease, which we classically say as APS 2. Carpenter syndrome is the full house phenomenon where all the 3 are present: Addison plus type 1 diabetes plus autoimmune thyroid disease. And this is a table from Harrison comparing the features of APS 1 and 2. The table is self-explanatory. The important points being APS 1 has got a monogenic inheritance. It is inherited in an autosomal recessive fashion. AIRE gene, autoimmune regulator gene, is mutant. Whereas APS 2, it has got a later age of onset. It is polygenic inheritance is there, and there is no specific inheritance pattern. APS 1, the patient would present in infancy itself with either hypocalcemic seizure or with candidiasis. So those are the earliest features in patients with APS 1. So the antibodies which are specific for APS 1 diagnosis include interferon alpha and interferon omega. It's very important. And for chronic mucocutaneous candidiasis, the pathogenic antibodies include antibodies against interleukin 17 and interleukin 22. So overall, interferon alpha and omega are the specific antibodies. For candidiasis, interleukin 17 and interleukin 22 would be the more specific antibodies. For hypoparathyroidism, anti-NALP5 are the specific antibodies. And for Addison, 21 hydroxylase and 17 hydroxylase are the culprit antibodies. And for premature ovarian failure, desmolase or the side chain cleavage enzyme and 17 hydroxylase are the important antibodies. So it is important to learn at least this interferon as well as interleukin 17 and NALP5 antibodies. These 3 are very, very important to know with regards to APS1. And how you are going to manage a case of APS3 is that we should rule out an underlying AI. The point we have emphasized throughout our discussion, all patients with endocrine, with autoimmune thyroiditis or even secondary hypothyroidism, before initiating thyroxine replacement, you should reliably rule from the history, clinical examination, or if possible from biochemical examination, there is no associated autoimmune adrenalitis. Now coming to other multiple autoimmune conditions with endocrinopathies. One is IPEX syndrome, which is immune-related polyendocrinopathy with enteropathy and X-linked recessive inheritance. So it is due to FOXP3 mutation. FOXP3 is the transcription factor which regulates the regulatory T cell function. So the regulatory T cell is involved in controlling the autoimmunity. So when the regulatory T cell is dysfunctional, the autoimmunity goes on unchecked and there will be multiple autoimmune phenomena. So it is inherited in an X-linked recessive pattern. The triad is enteropathy, early onset diabetes, which is similar to type 1 diabetes, and eczema. Can also be associated with autoimmune thyroid disease, and the specific treatment is hematopoietic stem cell transplantation. So IPEX syndrome also come under the heading of neonatal diabetes, where the diabetes is due to a specific gene mutation and presents before 6 months of age. Then you have the POEMS syndrome. As you all know, it is associated with the sclerotic myeloma variant, also known as Crowe-Fukase syndrome. VEGF is the serum. Increased levels of vascular endothelial growth factor is a serum marker. The hypogonadism is the most common endocrine feature, followed by type 2 diabetes. Then you have two more syndromes, the Kearns-Sayre syndrome with the typical triad of mitochondrial diabetes, hypoparathyroidism and hypogonadism, and also the Didmore syndrome with Wolframin gene mutation. Diabetes mellitus, usually the first manifestation around 5 to 6 years of age. There is defective insulin secretion, but there is no beta cell destruction as in type 1 diabetes. And following the early onset diabetes, the patient will also have optic atrophy and sensory neural hearing loss. And finally, about the Hirata syndrome. Hirata syndrome is a condition called as autoimmune hypoglycemia, where the patient will present with recurrent episodes of hypoglycemia due to the presence of anti-insulin antibodies. The anti-insulin antibodies will bind to the insulin, and thus the insulin will not be able to bind to its receptor when the patient takes a meal. And as the time passes, the affinity of the antibody to the insulin reduces, and all these bound insulin will be released all at once. So when the large quantities of insulin are suddenly released from this antibody pool, they will go and bind to the receptor, resulting in recurrent and frequent episodes of hypoglycemia. So at the time of hypoglycemia, because the insulin concentration is so high, the levels are often more than 1000 milli-international units per liter. So in a hypoglycemia, if you are encountering insulin more than 1000, the two possibilities is one, is it a factitious hypoglycemia due to insulin, or you are using an exogenous insulin, or you are using a sulfonylurea, or the third possibility is a Hirata syndrome. Hirata syndrome commonly occurs secondary to the use of certain drugs, especially the methimazole, alpha-lipoic acid and clopidogrel. These are the three most important drugs in clinical practice which can result in Hirata syndrome-like situation. And because this is an autoimmune phenomenon, it can be associated with other autoimmune conditions like SLE, rheumatoid arthritis, then B-cell CLL, etc. So how are you going to diagnose a case of Hirata syndrome? You can do a polyethylene glycol precipitation to neutralize the anti-insulin antibodies, and thereafter you can do an assay for serum insulin. So that is the diagnostic test for Hirata syndrome.